Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is Role of OCT in Detection and Correction of a Complication by a Provisional Technique in Left Main Coronary Artery PCI. The patient is a 51-year-old diabetic and hypertensive male who presented with a history of typical angina, which was crescendo in nature, NIH a class 2 to start with and progressed soon over 15 days to class 3. The routine evaluation by ECG and echo were normal, and a diagnosis of unstable angina was made, and he was further evaluated by a coronary angiogram. And coronary angiogram revealed an osteal LAD, critical osteoproximal LAD lesion, and also a very critical distal L6 lesion. The plan was PCI, and the strategy was to stent the distal L6 first for obvious reason, and to stent LAD lesion from LAD to left main. In other words, to treat it as a provisional left main. And the strategy we adapted here is port side port or report for short. Report for short. The LAD lesion was adequately prepared, and then a 3.5 into 22 millimeters test was deployed from LAD to left main with adequate length of stent in the left main. And the diameter of the stent was chosen according to the LAD diameter. After the deployment, the left main portion of the stent was optimized by port with 4 into 10 NC balloon. And as report technique requires, a distal recrossing of L6 was done, and L6 ostium was dilated with a 3.5 into 10 NC balloon. And following the first part as well as after the side branch dilatation with the NC balloon, 2 OCT runs were done, which showed a very well opposed LMCA stent after the first part, that is before the side branch distal recrossing into side branch, that is LCX, and also dilatation of the L6 ostium. Before that, the part resulted in a very good opposed stent in the left main. Now this is the report technique, that is the part followed by distal recrossing and an NC balloon into the L6, which was dilated there. And an OCT pullback showed a grossly malopposed stent following the side branch balloon dilatation. This malopposition was not only in the left main but also in the proximal LAD, as the stent rendered view shows there. So how to correct this malopposition? So there are two options. Routinely, any malopposition will optimize it by part with an NC balloon. But the uniqueness of the malopposition that occurs with report technique is the malopposition will go beyond the carina into the distal main vessel, which is LAD here. So for us to properly correct the malopposition, the part should be distal part. So the left main balloon, which is 4 millimeter diameter balloon, should be put into the LAD also and dilated there. So that would result in the shifting of the carina into the L6 ostium and jailing of the L6 ostium, and also distortion of the stent across the ostium of the LCX. The other option is to do a kissing balloon inflation followed by final part. The kissing balloon inflation will correct the malopposition in the proximal LAD, and the kissing balloon will be selected according to the diameters of LAD and L6. So there is no shifting of any carina, and also the carina will be kept in the center of the bifurcation by kissing. So the flow divider will be in the center, as well as the malopposition will be corrected by kissing balloon. And the procedure will be completed by a final part in the more proximal location in the left main. So that's what we have done. The resolution was of this problem was by kissing balloon of LAD and L6, as is shown in the first angiographic image, followed by part in the left main, and that the final image shows a very good angiographic result. And this is the final OCT, which is showing a very well opposed stent in the LAD and left main. And this is the sequence of OCT images in the left main. The first one shows, this we have kept here for easy comprehension. The first image shows the well opposed stent following the first part. The second image shows grossly malopposed stent in the LMCA following the side branch NC balloon dilatation. And the last image shows again well opposed stent in the left main following final kissing and the final part. So the take home message is the malopposition is a real complication following report, and the uniqueness of malopposition is it is not confined to the main proximal main vessel, but it will go well into the distal main vessel. And it cannot be corrected by near part. The ideal way to correct this would be kissing forward by part. The kissing will correct the malposition in the distal main vessel, which is LAD here, and the final part will correct the malposition in the LMCA, which is the proximal vessel. And it also illustrates the importance of imaging in recognizing this. Had we not done imaging at every step in this case, we would have missed this malposition following the side branch dentation. And it is better not to treat a huge vessel like left main in a provisional strategy with a report technique, because the side branch will be very huge in size, like LCX, which will require a 3 or 3.5 size balloon for dilatation. That will definitely malpose the stent from the opposite side of the vessel wall, which is LM to LAD. And better not to treat an LMCA with the report. It is better to treat an LMCA in a provisional strategy with a final kissing and final part. And we can take to report technique in a non-LM bifurcation like LAD diagonal or LCX OM. The popularity of report technique is because of the ease of doing. You need not have to put two balloons like in kissing balloon, which is a little more cumbersome. Here only we need to put one balloon followed by part. The technique is very simple to do, but the downside is the malposition that can occur, which can be corrected only by kissing balloon and the final part. Thank you very much.
Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is A Fracture in the Main. These are my potential conflict of interests. The patient I would like to present is a 68-year-old male presenting with ST elevation myocardial infarction and a chest pain lasting for 2 hours. He was previously treated for hypertension, dyslipidemia, and diabetes. On presentation, he was hypertensive and tachycardic with slightly decreased LV ejection fraction with some regional wall motion abnormalities. He had a fever 2 days ago, but he tested negative for COVID-19, and he stated that had previous renal failure. On ECG, you can notice an ST elevation in AVR lead, but also there's a striking ST depression in D1 and precordial leads. On initial angiography, there's a long calcified lesion in proximal and mid segment of the right coronary artery, but you can appreciate a critical lesion in the left main stem of the left coronary artery. More coronary angio showed that left main was stenosed in a distal segment with preserved flow and without stenosis of the ostial segment of the LAD and SIRC. We don't usually do scoring when we have a patient in acute coronary syndrome, but in this patient, right coronary artery gave 10 points and the left main 14 points, which yields 22 points in syntax 1 score. Syntax 2 stated that there's an equipoise between suggested treatment of PCI and CABG, and the surgical Euroscore 2 yielded relatively high mortality due to urgency of the procedure and an ongoing ischemia. Recently developed Syntax Score 2020, which used the data from the Syntax trial and another 3 trials that analyzed patients with multivessel disease, showed that there's a slightly higher mortality with PCI and MACE events compared to CABG. And now, none of these studies have not taken into consideration patients with ST elevation myocardial infarction, and previous generations of drug-eluting stents were used, and most of them have never used imaging in the procedure. So the question is what to do with this patient. There's an option of PCI in the same procedure, or send patient to surgery, do heart team analysis, or just wait and see what will happen. We decided to do the PCI in the same procedure, and we pre-treated patient with DAPT, used a radial access, and placed workhorse wires in LAD and circ, pre-dilated the left main and LAD with non-compliant 2.75 balloon, and then implanted Synergy 3.5 times 24 stent. The pump was done using 4.5 NC short balloon. And the result was relatively okay regarding proximal LAD. We used a provisional strategy, but there was a sluggish flow and an incomplete opacification in the left main, pointing towards something was not okay. We decided to do stent boost, and unfortunately, based on this image, you cannot easily discern whether this is stent distortion, fracture, underexpansion, or breakage. So we've decided to do IVUS. Despite relatively preserved lumen and diameters, there was a gross malapposition and incomplete expansion of the stent in the LAD and also in the left main. But you can also notice a very calcified lesion that takes up to 180 degrees of circumference and an incomplete apposition of the stent in the left main. We've decided to repeat proximal optimization and also to do a distal optimization with larger non-compliant balloon, and then implanted short, large diameter Synergy stent 4.5 only in the proximal, in the left main, and then repeated POT with 5.0 NC balloon. We've repeated stent imaging, and as you can see that there is a well-expanded stent in the left main and LAD. And on the angio, the flow looks good and the expansion of the stent looks relatively okay. Also, in another projection, you can appreciate that the ostial segments of the circ and LAD are without significant stenosis. We repeated IVUS, the diameters and cross-sectional area were greater, and you can see that there's an optimal, or I say adequate, expansion of the stent in the left main. And the patient stayed in hospital for 3 days, and he was seen 1 month after the procedure, doing okay. And we scheduled repeated PCI of the right coronary artery and angiography, and probably imaging of the left coronary artery. But what has to be done now is to do a stent distortion analysis in this patient. We use Synergy platinum chromium stent, which is thin strut stent with abluminal polymer and sirolimus as an antiproliferative agent. And this stent comes in various diameters, and for the large vessels, it has 10 crowns and reinforcement of 2 to 5 connectors. As in bench study, this stent can be expanded up to 6 millimeters, but what can be compromised is the radial strength and adequate scaffolding of the very calcified left main in this situation. And also, imaging in acute coronary syndrome can and should be used, because risk of using imaging is smaller than the risk from suboptimal procedure. It can be initiated at any point during the procedure, but the results should be interpreted cautiously. This is my presentation, and I'll thank you for your time.
Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. I am Dr. Sridhar Kasturi, Head of the Department and Senior Interventional Cardiologist from Sunshine Hospital, Hyderabad, India. The title of my presentation is OCT Guided Decay Stenting of ISR of LAD-D1 Bifurcation. This is a 65-year-old gentleman, known hypertensive. He underwent multiple interventions. Presently, he got admitted for PCA of ISR of LAD-D1 bifurcation site under OCT guidance. Angiogram shows L6 is stents very well patent. There is a diffuse long segment lesion involving the proximal to mid LAD, and mid LAD appears to be fine, and distal to the stent there is a mild lesion. LAD, a very tight severe stenosis of the mid diagonal. You see the very tight stenosis of the mid portion of the previously stented diagonal stent. And you can see in this view, you can tight stenosis proximal to the LAD stent, and right coronary non-dominant, distally totally occluded. Then wide LAD and diagonal and pre-dilated with 1.5 balloon, and then we acquired the OCT images. The OCT image very clearly showed there is a significant block burden proximal to the stent. There is a severe atherosclerotic block with a healed block and a lot of lipid-rich block. And if you see the analysis, distal to the stent also there is a significant block burden, distal edge restenosis due to atherosclerosis, and the remaining portion of the stent appears to be fine. And then if you see the diagonal, this is the proximal portion of the LAD. You can see there is a lipid-rich block, plenty of macrophages, healed previous block rupture, and intrablockler hemorrhages. You can see very nice block, lot of block burden proximally. And if you go to the classification management of ISR, is it mechanical? Is it because of the biological cause, or mixed pattern CTO or more than 2 stents? So based upon the etiology, you can also choose the treatment of choice. If it is mechanical, under expansion, mechanical cause due to under expansion, high pressure balloon, or DEB can be used, or stent fracture, replant disc, internal hyperplasia. You can do the DCB or DES or VBT. Neoarthrosis, you can treat with the DCB or DES. Or neoarthrosis with severe calcification, you can do the block modification. So it throws a light OCT. What is the mechanism of the ISR and what kind of treatment you can choose? DES, DEB, both are under class 1A. So highly recommended. You can choose any modality. And this is a recent third report of the international DCB consensus group. What they emphasize mainly, block modification is very, very lesion preparation key in producing the best results for DCB. You can use the angioscope, you can use any cutting balloon, or if severe calcium is there, you can do the block modification with the block modification devices, achieve the 1:1 ratio, and still suboptimal result is there. Then you can go with the DES if the optimal mean luminal area is there, adequately prepared without any flow limiting rejection. You can do the DCB. Even after DCB, still suboptimal result is there. If you can do the FFR result is positive, then you can go with the DES stenting. And here the study has shown very clear, more number of multiple layers of stents, the DCB results are far superior compared to DEB. Compared to DES, the DCB results are better. Here they compared 1 year MACE rate for patients who underwent more than 3 metal layer drug-eluting stents for ISR. Read-S, you see the MACE rate 57.9% versus 20% in DEB group. That means results are far better with the DEB group. Then again, pre-dilatation of the LAD, and subsequently we implanted the 2.25 into 34 resolution on stent in D1. We kept the 3 mm balloon in LAD to crush the stent, and the D1 stent crushing was done with the 3 mm balloon. This is the implantation of the disc in the D1, slightly extended into the LAD and crushed with the 2.5 and then 3 mm balloons. And this is the angiogram after crushing. Here we faced a lot of problem in crossing. So the crusher segment after performing the first kissing balloon is the opening of the stent studs using 1.5 balloon. You are recrossing. Then you can see the first kissing, that 2.5 and 2 mm balloon. Then upsize to 2.5 and 3. Here we are facing a lot of problem to cross the LAD, that crushed portion. You can see we are unable to cross here despite using the guide liner. Then what we did, we used the balloon anchoring, and we tracked the guide liner over the balloon and crossed beyond the crushed segment, because otherwise this crushed segment was not allowing us to place the stent. So then we put the guide liner beyond the D1 and bifurcation stent, and you can see very clearly how we are placing. You can see very clearly after this is the dilatation, we see the guide liner tip is beyond the LAD-D1 bifurcation. Despite multiple balloons, we were unable to cross. Finally, we could cross the lesion with using the guide liner over the balloon tracking method. Then we put the stent, that is 3 to 38 mm resolutive onyx stent in LAD. You can see the stent is expanded very well. And again, recrossed with 1.5 balloon. And then we use a 3 mm balloon to LAD and 2.7 12 mm NC in D1. So this is the second kissing. So again, dot of diagonal was done and dot of the LAD stent was done. And you see the nicely expanded. And this is the nice part was performed with the 3 and 3.5 balloons. And you can see the OCT image very nicely. He expanded the diagonal stent, expanded the LAD stents, and the proximal LAD stent area is 8.9 square mm, 8.7 square mm. And at the bifurcation side, 10 square mm. And distally, you can see 9 square mm. And diagonal stent is nicely expanded. This is the OCT run of the diagonal. You can see the mid portion, there is significant under expansion, that is about 77% only. And you can see very clearly the LAD expansion is very beautiful and nicely expanded. And you see the LAD diagonal stent is not expanded in the mid portion. Then again, we took the 2.75. We gave a high pressure prolonged inflations because under expansion has with the high rate of restenosis rate. So if restenosis if you want to avoid the restenosis, you should get the adequate expansion and see that the entire disease segments are covered with the stent. Bifurcation mode, you can see the nicely open D1 and side by rendering of the D1. And you can see the nicely expanded stent of the proximal LAD and mid LAD and the diagonal. And this is the D1 post direction with because under expansion was there, optimized with 2.75 balloon, high pressure, prolonged inflation. This is the final result. You can see the nicely expanded the proximal LAD stent, mid LAD stent, and LAD D1 bifurcation side as well as the diagonal stent. So OCT evolution ISR is needed to know the mechanism of ISR and in choosing the appropriate treatment strategy. This patient showed a significant plaque burden, proximal LAD, which is lipid-rich plaque. That's the reason it was covered with the DES. Diagonal stent was under-expanded, which was expanded it well with the REDES and optimized with the OCT. Difficulty in crossing crushed segment site of LAD was managed with the guide liner with balloon tracking. Decay crush stenting of LAD-D1 bifurcation was done with the optimization using OCT due to recent favorable outcome data. Thank you one and all for paying attention.
Good afternoon, dear Chairman. Thank you very much for this kind invitation to present this case of complication at the EBC meeting 2021, the importance of POT in Culotte technique. This is a male with normal risk factor treated 4 months before on LAD diagonal with decay crash and proximal side optimization with the residual lesion on circ. This was the decay crash with PSO. The PSO is the immediate post-dilatation with a bigger non-compliant balloon of ostial side branch before the crash. This was the index procedure. The LAD diagonal at that time was good and you see the lesion on circ and posterolateral. The operator decided to treat this lesion with a culotte, and this was probably the first wrong decision. Were wired both branches, pre-dilated, the OM, implanted a stent 2.514, then this was the result, rewiring from OM posterolateral. You see already with some difficulties, pre-dilated posterolateral and immediately implanted a stent on circ posterolateral. Then post-dilated only with the balloon used to pre-dilate extensively with so quite good result up to this time. Then rewired the OM and opened the struts there with the same 2.5 balloon. And actually this is an enlargement to see the rewiring of posterolateral, and you see the operator had some difficulties. It was too fast, and in some way he rewired. He did a kissing with a bigger balloon, kind of very late pot with a 3.0 balloon there, and a very, very late pot then. And this was his result, but he had some doubt. The angio was not so good, and he did a stem boost, and the stem boost was ugly, terrible. So he did IVUS, and although the angio was not so bad, this showed multiple place where the stent was crushed, so the wire went in and out many times during the first rewiring or the second one. The so-called repair of the operator was done dilating extensively and crushing completely the malapposed stent, and then implanting another stent on the main branch. But this was not completely successful on repair what happened at the bifurcation and at the origin of the two side branch. You see the result also with another stem boost is ugly, terrible. In this same case, different stent techniques were used, one in a right way with PSO and decay crash on LAD, and one in a wrong way with a culotte without pot on LCXOM. To have a complication, as in flight accident, you need often more than one mistake. Most of the time, if short side branch lesion, one stent and provisional is the way to go. This case was definitely a one stent technique on circ, also for the angle of the two branches. Never be so sure distal or proximal stent in culotte to anchor to the wall and to have space for kissing and most for pot. The new DK culotte recommended also required the pot. Culotte is possible also when the diameter of the distal branches are different in the limit range of the maximal expansion of the stent used, but then is also more important, is essential, the pot before the rewiring. Intravascular imaging is very useful, most into stent technique, to avoid and recognize the possible pitfalls of the complex PCI. When there are more steps, it's more possible to do mistake, but it's most important to be able to use this imaging technique in a proper way. If you can use imaging in bifurcation, it's better to use from beginning. The stent boost can be used sometime in situation of lack of IVUS OCT, but also there the clinical judgment is more important. Pot with a bigger balloon as a first step after stent implantation is essential in all bifurcation technique, but most in cases of double stent one, like in DK crash, the PSO for side branch, especially to avoid rewiring problems. The final result, when not done in a proper way from beginning, is never perfect, and most of time completely unacceptable, most if you don't have huge experience. These steps, pot and PSO, make procedures safer and are essential. Thank you very much for your attention. I'm open for your question.
Respected Chairman, sir, thank you for the invitation to present at the EBC 2021. The title of my presentation today is a double tap in left main trifurcation, triumphs and tribulations. So this is my patient, a 65-year-old gentleman with an anterior wall MI 1 year back who underwent a primary angioplasty with a stent to the proximal LAD. And now he presents with effort angina. So if you see there's a lesion in the left main extending into the circumflex, ramus, and the LAD. It's a Medina 1111. The right coronary is normal. So to plan this angioplasty, we first did an OCT. And this is what the OCT showed us. The stent in the proximal LAD was underdeployed. And if you look at the area of confluence, there is a ruptured plaque there, which is healed with an area of 2.3 millimeters square. The left main had a calcific nodule with an area of 4.2 millimeters square. The 3D gave us a very important point, and that is the ostia of the circumflex and the ramus was a single ostia. And that was an important point. So for the bifurcation planning, the physiology showed us that the lesion in the left main was significant. It was 0.74 with IV adenosine. With the OCT, we got this information on the side branch that was a single ostia. We got the morphology, length, diameter decided. So what are the options we have? The simple option is to just go and do an LM crossover, or to do a crossover and kiss, or to do a tap, a trifurcation tap, a double T with a trissing. Now, what's a trissing? Now, according to the dictionary, a trissing is to kiss two other people at once, or a three-person kiss. And that's what we thought we will do. So we started off with the left main LAD stent. We put a 3.533. We did a pot with a 4.5. And the result looked good. So we removed the jailed wire from the circumflex and the ramus, recrossed the circumflex and kissed it, sequentially recrossed the ramus and kissed it, and finally we did the trissing. So here we recrossed the circumflex with the balloon, and then we kissed that. Then we recrossed the ramus, and we kissed that with the left main, and then finally we do this trissing with 3 balloons, one to the left main, to the LAD, to the circumflex, and to the ramus. But after this, we were not too happy with the result, as you can see over here. The lesion in the circumflex and the ramus remains. So we did an OCT at this point. And this is what the OCT showed. The 3D showed us there was a strut across the side branch ostia. Actually, you can see all the 3 wires here. The one wire going into the circumflex, the second wire going into the ramus, and this is the wire into the LAD. Somehow not satisfied with this result, we decided we're going to do a double tap. So now this is the double tap. A stent in the circumflex and a stent into the ramus. Deployed that, and again did the trissing. The result looked good, and I guess you would agree with me that the result looks good. And we thought we were going to finish it off with a pot. So we did the pot. The final result looked quite satisfying, and we thought we were going to come out with a final OCT. And this is what the OCT showed us. It's quite a surprise to us, because if you realize there's thrombus everywhere, and that's quite acutely. Right at the area of confluence, extensive thrombus. Into the left main, again extensive thrombus. And the 3D looks full of thrombus at the trifurcation point. The patient was clinically stable at this point of time. So we checked the ACT, and that was 340. But again, we gave heparin. The patient was on Plavix. So we changed it to ticagrelor, and we loaded him with 180 milligrams. We gave him tirofiban infusion. And now we kissed again. But we just did a kissing now. The left main and the circumflex. And that's the result we got. Patient remained stable. So we did another OCT. And thankfully, the thrombus is still there, but definitely less. And that's how the 3D looks. The ostium, the circumflex is open, the other ostium is full of thrombus. But because the patient remained stable, we continued the tirofiban infusion and shifted him to the CCU. The next day, we took him back. Angio looked pretty decent. And we thought we were going to do another OCT at this point of time. So we did another OCT. And happy to note that the thrombus is much, much less. But it's still there. You can see the struts here of the tap. And this is what the 3D shows. You can see the struts of both the stents in the ostia. But since he remains stable, we decided that we're just going to continue him on aspirin and ticagrelor and discharged him. And everything seemed good. We got the results of the clopidogrel genotyping, and which showed that he was an intermediate metabolizer. So we continued him on ticagrelor. However, 2 years later, he came back, now with class 2 symptoms. And this is what the angio shows. We have got an ISR that's involving the ramus ostium and the circumflex. So what do you do at this point? We decided we're going to do another OCT. Now, this is what the OCT showed us. If you look at this view over here, you can see a lot of ingrowth into these struts, and this is how it looks at the area of confluence. A lot of neointimal growth at the strut, and the 3D shows neointimal growth. The entire ostia is divided into 2 particular ostia. So the take home from this is that trifurcation is a messy affair. You must use the minimal number of stents if feasible. There should be a low threshold for CABG, and an imaging is absolutely mandatory. Ticagrelor is always preferable because clopidogrel resistance is a reality. A routine PRU measurement should be done and know when to stop. And like in this case, I think a femoral approach makes life easy. Thank you all for your kind attention.
Dear Chairman, thank you for the invitation to present at EBC 2021. Today, I'm sharing with you a challenging case of distal left main angioplasty in acute coronary syndrome patient with multivessel disease. 46-year-old male with multiple coronary risk factors. In January 2020, he had non-ST elevation myocardial infarction as first clinical manifestation, and he was admitted to another hospital with persisting chest pain started 20 minutes before his arrival to the hospital. He was stable. T-troponin was 470, creatinine was 0.9. Medical therapy was started with heparin, aspirin, nitrates, and beta blocker. Then he was transferred to our hospital for coronary angiography. He arrived with stable condition, chest pain was reduced, and he was dropped to cath lab. Angiography showed multivessel disease with chronic total occlusion of LAD, chronic total occlusion of right coronary artery, severe stenosis on proximal dominant circumflex, as the bifurcation with a huge marginal, which itself has a long lesion proximal segment, and severe stenosis on distal left main involving both LAD and circumflex. So syntax score was 41. Then complex anatomy with high syntax score, and first option in this patient should be surgery. But we have unexpected clinical evolution, since soon after angio and patient still in cath lab, chest pain was increasing with ST elevation now in inferolateral wall. We decided to proceed for angioplasty, and given the high-risk procedure, we selected the femoral access with 7 French guided catheter and contralateral femoral access 6 French, ready if needed for mechanical support. Soon after wiring the 3 branches, hemodynamic stability was deteriorating to cardiogenic shock, systolic blood pressure fall to 85, and oxygen saturation to 91%. Then we have 2 essential issues now around mechanical support, which and when, and angioplasty, only culprit lesion versus complete revascularization. We decided for mechanical support before proceeding, and angioplasty only to culprit lesion, that means left circumflex, marginal, and distal left main. So intra-aortic balloon was implanted, patient was intubated with anesthesiologist assistant. Then we proceeded to complete the procedure. We started from the bifurcation of proximal circumflex and marginal. So since it was complex procedure, we selected the dual stenting strategy, and that was modified T-stenting or reverse step, starting stenting on marginal with a balloon in circumflex, then soon after stent delivery, kissing balloon inflation, then stent delivery in main vessel, and in this case, it was long stent covering a whole proximal segment of circumflex and crossing over to left main till the ostium. So completing also the stenting or provisional stenting on distal left main bifurcation. Then we proceed to optimize the procedure with POT in proximal circumflex and proximal left main, and then we recross to marginal and second kissing balloon inflation, and again proximal optimization on circumflex and on left main. After the POT in left main, we had total occlusion of LAD. Then we recrossed the stent to LAD and opening the strut with 2.5 balloon, and then completing the procedure with stenting proximal LAD prior to first diagonal with tap technique, which was optimized by kissing balloon inflation, and final POT with 5O balloon at 18 atmosphere in left main. And this was the final angiographic result. Soon after this procedure, hemodynamic stabilization was restored, ST elevation regression was obtained, spontaneous systolic blood pressure was 110, and intra-aortic balloon was kept 2-to-1 for 12 hours following the procedure. Intubation removed on the following day, that means 18 hours later. Patient out of intensive care unit on second day with complete recovery and with no quite normal ejection fraction on echo that was 0.52, and hospitalization was free, and patient was discharged after 7 days with a planned second stage procedure for LAD and right coronary artery at 3 to 4 weeks later. But we have another surprise now. At nearly 1 month, patient was coming back for recurrent angina, and now angiography was showing tight stenosis on ostial left main. I was taken and showed that there was no stent on ostial left main. There was only plaque with tight stenosis, and soon distally to this plaque, the stent was well apposed, well expanded, and not before. So this was treated with stenting on ostial left main with a short stent, 4.5 per 8 millimeters, deployed at 16 atmosphere, and post-expanded with non-compliant balloon 5O at 18 atmosphere. And this was the final result after proximal LAD, ostial left main stenting. Then we proceeded to complete the procedure for LAD recanalization, which was performed successfully by antegrade approach. The total occlusion was easily crossed with Gaia 2 wire. Then LAD was stented, and this was the result after LAD stenting. Then an IBUS was taken in order to check the previous procedure on both bifurcation on distal left main and circumflex. IBUS confirmed the optimal result. Everything was in place. Stent was well apposed and well expanded at all sides of both bifurcation. And finally, we completed the revascularization with another antegrade approach for total occlusion on right coronary artery, which was performed successfully during the same procedure. And now at 22 months follow-up, patients is still event-free. So my final regards that high-risk patients are not the ideal candidate for procedure, particularly in emergency settings. However, in some patients, PCI represents the only option to rescue the patient. The recommendation in this setting is to make it simple and fast as much as possible, and so to do what is necessary to restore hemodynamic stability in these patients. Left main osteal mist might be due to longitudinal stent crushing by guiding catheter or stent shortening with overexpansion of inappropriately sized stent. Unexpected complication might occur despite the experience and the meticulous work of the operator. Thank you very much for your attention.